Hi, Tom Dunlap. Okay. Greg is on. So I have 1, 2. Suho. Okay, Linda is there. Jeannie, we do have quorum. Tom, we're waiting to see you. Hi, Tom. Good to see you. And we're going to go ahead and get started. It is 2 o'clock. Hi, Greg. It was so good to see everyone. It's been a month since we were last together. It seems like 6 months, a long time. So I really missed seeing everyone and seeing your gorgeous faces, and hope you're having a wonderful early spring. Getting kind of warm out there for these conditions, but yet it's gorgeous. With that said, Jordana, we do have quorum. Are you able to capture or Suzuho capture who is on, who are board members?
We've got, do we have a Brill taking notes today, Suzuho?
It's me, Lindsay.
Lindsay, great. Thank you, Lindsay. Yes, I'm sure Lindsay has captured everyone on here, and we'll turn it over to you, Marky.
Okay, thank you very much. I will first ask if there's any changes to the agenda. If not, I'd like to have a motion for approval of the agenda as stated.
So moved.
Thank you, Tom. Second is Linda. All in support, right hand goes up. Okay. Now we have minutes from the previous meeting in March 11th. Do I have a motion for approval or corrections to the minutes? Tom?
Also so moved.
Thank you very much. Do I have a second?
Second.
Thank you, Linda. All in support, right hand. Thank you very much. I think all of you realize that Public Health Month or Week is national tradition and has been for a number of years. And needless to say, this is a week of celebrating public health. And in preparation of today's meeting, I pulled off what our presidential action was relative to Public Health Week. And the declaration was on April 5th. But I'd like to read just a little bit of it. National Public Health Week has increased significance this year as our nation mourns loss of over 500,000 lives to COVID-19. And as we have come to recognize just how essential our public health efforts and public health workers truly are. Whether it is the scientists and researchers who develop life-saving vaccines in record time, or local leaders who have taken evidence-based action to keep their communities safe, or the staff and volunteers who have worked to slow the spread of the virus through testing, case investigation, and contact tracing, or all the doctors and nurses, clinicians who continue to provide around-the-clock care to those who have fallen ill. Dedicated public health professional on the front lines of our response to COVID-19 deserve all of our gratitude. On a local level, our public health team has worked tirelessly in providing excellent leadership during this pandemic. From the beginning, in collaboration and partnership with so many partners, Pickens County residents have been first and foremost at the forefront of all the efforts of our public health team. On behalf of the board, I really want to thank every member of the public health team. And today, when I was reading the newspaper and saw Joe DeSalvo's short little tribute to all of the volunteers who are working at the Benedict tent. Wow, what a community effort this has been. And needless to say, Jordana, we appreciate and love all of your leadership. You've done an amazing job taking over from Karen and leading this team forward. So thank you so very much.
Thank you, Marky. And let me please return, the recognition of this entire board who has been, thrust into the community spotlight of what the Board of Health does, what its responsibilities are, especially amidst a pandemic, and have appreciated how everyone has shown up, has listened to constituents, has brought the perspectives of protecting our entire community to the table. Both our health, our economic health, and well-being of everyone here. So thank you right back to the board for your dedication and commitment this past year, and appreciate it.
Thank you, Jordana. Thank you very, very much. Does anyone have any other comments for National Public Health Week? Okay. If not, we're going to move on to board terms. Suzuho.
Great, thanks, Mickey. Hi, everyone. Want to echo Jordana's thanks to you all for National Public Health Week as well. Also wanted to talk through some board terms. So as we've talked about before, we have 2 seats that are up in April. Right now, it sounds like the BOCC is still in the process of interviewing a few final candidates, or not final, but a few more candidates before they wrap up that process, and hoping to appoint positions, hopefully by the end of this month. So we're grateful for Brent, who's willing to stay with us, as well as Marky through the end of this month, until we hear more about what those future appointments may look like. Any questions around that timeline of where we are right now? Okay, great. And with that, I also wanted to share that Brent has indicated that he will not be running again for another term. So we wanted to spend a few moments just to recognize him and thank you, Brent, for everything that you've done for the board with this pandemic, and prior to COVID, to really supporting this department as one of the first round of Board of Health members who helped create this department a few years ago. And we're just so grateful for all the expertise that you've shared, even at the beginning of COVID, when we were talking about air quality and airplanes and travelers, you really were able to provide that unique expertise for us. So we have a small gift that's coming your way. It's artwork, hopefully, that you can enjoy, thinking about the global aspect of your previous work, as well as the global aspect of the community response that you helped out with over this past year, especially, and then an electronic card coming your way as well. A huge thank you for everything that you've done.
Well, thank you. It was an unexpected pleasure, really, to work with everybody, and I didn't expect, and I don't think the public knows really how dedicated everybody was, how seriously everybody took it, how it was completely apolitical, although I got feedback from people in town that they thought that there was some, occasionally some politics involved, and there absolutely wasn't. And the amount of work that the staff did, because every now and then we would say something and then they would have to go out and do something over a weekend or whatever it was just huge, the amount of work product and whatever else that they put out. And I just wanted to say that this was a unique experience, well, for all of us, but especially for me, during this sort of unprecedented time in our society. And I really, I won't forget it. I really enjoyed it. And I hope we did something meaningful. And in fact, I know we did. So thank you all.
Thank you, Brent. I tell you, you're an awesome trooper. I just love your comments and your thought process. And wow, you've never, ever missed a heartbeat when it comes to all the work that we had in front of us during this pandemic. So thank you. Thank you. Thank you. Thank you. But you know what, Brent, you can listen in on these meetings and send some comments to us. We have cell phones.
Marky,
So
can I say something real quick?
Absolutely.
Yeah, I just want to thank Brent. You were one of the first members of the new board when we transitioned from the old board to this one. And when we barely filled that small conference room up in the county building. And now we have up to, what did we have? Our record is 1,100 people
Yes,
participating. Anyway, thank you so much for hanging in there, going through what was a major transition from a quiet, fairly quiet board to a very, very visible board. And I've enjoyed, and I think we lost you.
I'm there, aren't I?
Oh, you're there? Okay. Oh, there you are. I just enjoyed all your comments and your frankness and just your willingness to speak up and question what was going on or support what was going on. So anyway, I very much enjoyed working with you, and sorry to see you go, but appreciate the experience of having worked with you. Thanks.
Thank you. Thank you very much.
anyone else? Okay. Greg?
Yeah, thanks, Marky. Yeah, I just wanted to pitch in a little bit. I agree with everything that's been said. Brent has been stellar, and I just wanted to share a memory. My first memory really with Brent was traveling to Denver and meeting him at the Capitol, where we both testified on behalf of the nicotine and vaping issues. And I was struck by, one, his calm in the, going into a daunting situation, and his reason. And I really learned a lot just in the short time on the board then, and then since. I feel as if Brent has been, he's clearly a captain who can steer us through a storm. And I really appreciate that. And I've already written him a letter to say, I may be calling on you again, and certainly as I think Ann said, is you've got our numbers, or Marcus said, you've got our phone numbers, pitch in, I'll expect to hear from you. And so I'm hoping that's the case, but I also wish you calmer and stress-free times ahead. Thanks.
Well, thank you. If I'd have thought this epitaph, if I'd have known about this ahead of time, maybe I wouldn't have left. But thank you. No, I think I spent enough time here. It's time for somebody else with another viewpoint. But you're right, Greg. I do remember that well, and I even remember the name of the popcorn lung, and popcorn lung, and that was bronchiolitis obliterans. And I thought anything that had the name obliterans at the end of it, you don't want. Anyway, thank you.
Okay. Moving on, Josh. Little data update. And then we hope to see some good news coming today. So Josh.
Okay, thanks, Marky. Next slide, please. All right, well, so I wanted to start off by looking at our incidence rate along with the population that would still be susceptible to severe infection. So this is looking at the population who has not yet been fully vaccinated. So Pickens County here is in the blue, and you'll notice that our incidence rate over the past week has begun to decline quite readily. We were plateauing at a pretty significantly high rate and did have the #1 or highest incidence rate in the state for a few weeks at the end of February and through March, but have since seen a decline in our incidence rate, which of course is always something to celebrate and be excited about. But I did want to show, what things look like across the state as well. So that dark red line is the state's incidence rate, and it's harder to see on this graph, but it has been increasing recently, even though, we are seeing fewer people who are susceptible to severe infection, just given that we're seeing more people vaccinated across the state. So, I think really the message here is, we're definitely seeing some good news right now that our incidence rate is declining, but we know that across the country and across the state, rates are going back up. And so it's hard to really interpret our incidence rate at a more national or global level at this point, just because we know that, things are, not looking as promising, unfortunately, across the country, especially. Next slide, please. So part of the reason why we're seeing this decline in our incidence rate is because mobility has decreased. It says selected states on there, but Pickens County is in the dark blue. And so you'll notice that we did peak with proportion of visitors who are visiting Pickens County on March 31st. That's where that tall peak is there on the right-hand side. And then since then, I've seen a very rapid drop off of visitors in Pickens County. And we know from past meetings that we've discussed that when we see an increase in mobility from residents, from visitors, that correlates very well with our incidence rate, just when there's more crowding overall. And so, looking at these rates here over the past 10 days or so and seeing a decline in the visitors per resident data, it's not unexpected that we would see a decline in our incidence rate, just several days after that decline. Next slide. So then did want to point out, what's going on across the country, as I alluded to 2 slides ago. So Michigan is really leading the pack when it comes to newly reported cases of COVID-19. They currently have the highest incidence rate of any state in the country. They also have, I believe, the second highest proportion of variant cases detected in the country. So that is definitely a reason why they're seeing such a significant increase in their cases, despite having 20% of their population fully vaccinated and 32% partially vaccinated. On April 4th, they had their second highest daily toll of cases at any point throughout the pandemic. So the message here is that, while we do have vaccines available and while they are extremely protective for those who are being vaccinated, we still have a very significant proportion of the population that is unprotected and has not been vaccinated yet. We're still seeing increases. So those vulnerable populations are the ones who are being impacted most heavily at this point. We're seeing in Michigan, many cases among children, and then many more cases among just younger adults. So overall, individuals that are 65 years and older, they are seeing much lower incidence of cases. However, our younger, the younger age groups are seeing much more significant impacts from COVID. And so, the question is Michigan what's in our future? Is Michigan what's in Colorado's future? And it's hard to answer that question. But we know that with the increase in variants that we're seeing, we know that we'll continue to see an increase in variants. And so, it wouldn't be surprising if we were to see another increase in cases, just given the abundance of variants now across the country. Next slide, please. So then want to show hospitalizations in Michigan as well. Again, we have a significant proportion of the population in Michigan who are protected and who have been fully vaccinated. Half of the hospitalizations in Michigan are individuals that are under the age of 60. So right now, the average age of patients in Michigan is 54, whereas it was 66 in the prior surge. And they're actually expecting that hospitalizations in Michigan will likely peak and be higher than ever recorded in Michigan over the next week or so, which is extremely concerning, especially knowing that we have 25% of residents of Michigan who are fully vaccinated. Again, they're protected. We're not seeing as nearly really any hospitalizations among individuals that are vaccinated in Michigan. There might be a handful of people that don't have proper protection, but for the most part, vaccine is providing significant protection for those age groups. However, the rest of the population is not being protected. So they're just, again, seeing just a huge surge of hospitalizations. 4 of their hospitals in Michigan are at 100% capacity, and then 5 are at 99% capacity, meaning they only have 2-3 beds available. And many of those hospitals are in Detroit and Ann Arbor, the bigger cities in Michigan. So again, just if this is sort of a harbinger, of what we could expect, it's concerning just to see, the extent to which these hospitalizations are increasing there. Next slide. So then just wanted to look at, what are other countries that have similar vaccination rates seeing? And really it's a mixed bag. So if you look at the US in the top left here, when I pulled the data, 19% of individuals across the US were estimated to be fully vaccinated, with 33% partially vaccinated. And you'll see that we've sort of, stalled a little bit. We were seeing a very sharp decline, and now we're kind of just in this holding pattern, waiting to see what's going to happen in this race against variants and vaccines. And then if you look at Chile and Bahrain over on the right, and then the bottom left, they've been seeing increases, even though their vaccination rates were pretty similar to ours. And so what this tells us is that, while the vaccinations are helpful and they're useful and they're beneficial, right? It's the same thing as with Michigan. There's still a significant proportion of the population that is susceptible. And we have to reach a much higher level until we can feel confident that, case counts are truly going to come down and a significant proportion of the population will be protected. But then if you look over on the bottom right, which is Hungary, they have slightly less proportion of their population who are fully vaccinated, and they are seeing a decrease. It's hard to know whether that's due to vaccinations or other factors. But, I think that, again, the idea here is that different countries with different vaccination rates are seeing, different trends, right? And so what that tells us is that, vaccinations are playing a huge role among those who are vaccinated, but they're playing less of a role in those who are not currently vaccinated or not eligible to be vaccinated. Next slide. So then looking at just variant count here in Pickens County. So we do have 40 B117 cases with 70 suspected at this point, and 18 B1427s or 1429s. And that's the variant first detected in California. And then if you look at the bottom left on the map here, you can see which states are experiencing the most number of B117 cases. As I mentioned, Michigan, I believe, has the second highest total number of reported B117 cases. You see Colorado is dark blue on there as well. We've detected over 750 B117 cases in Colorado. And so that definitely plays a role when we're looking at incidence rate and whether or not cases are going to increase. And then over on the right-hand side, I wanted to mention that, or show that, the rate of detection of variants in Pickens County is the second highest among the state, only behind Rio Blanco, who had an outbreak of the B1427. And I believe they had 18 cases there that were all linked back to this one variant. They had them all sequenced. So we're only really lagging behind Rio Blanco, but you can see compared to other counties, our rate of detection is significantly higher. That's in part due to just a higher level of surveillance in Pickens County than in other counties. But it also plays a role, again, when we're talking about incidence rate and seeing our incidence rate, being higher than other counties and being an international hub. It's not surprising that we would see more variants, but definitely surveillance plays a huge role in detection of these variants. Regardless, point is we have a significant number of variants. We have more variants detected than the entire state of Rhode Island, which has a population over 1 million. So we're just doing a lot of detection here and trying to survey as much as we can. Next slide. So then just wanted to discuss what the concerns are with the B117 as more research has come out. So as of the 7th of April, the CDC has reported that the B117 is now the most prevalent COVID lineage in the country, which is what was expected. Several months ago, CDC predicted that by end of March, B117 would likely become the most prevalent lineage, and that has come true. More research is showing as well that children are much more likely to be infected with the B117 than any other variant. So, we have children who are already a vulnerable population based on not having access to the vaccine at this point. And now we have a more prevalent variant that we know is more likely to infect children than other variants that have circulated previously. So, the reminder here is to really, do our part to protect children who don't yet have the opportunity to be vaccinated. And then in Italy, this is sort of mimicking the second bullet point. 10% of the individuals in this village in Italy had tested positive for COVID on February 3rd. 60% of those were infants and elementary school age children who then passed the virus on to adults. So again, there is an increase in the amount of children who are testing positive after exposure to the B117 variant. And then Dr. Osterholm, who is a respiratory disease epidemiologist and was a former advisor to President Biden, is concerned just with overall transmission among children, and is really, echoing and mimicking the need to protect children as we move forward and as we consider additional steps that we need to take to continue to contain this virus. Next slide. And then wanted to share some preliminary results from the analysis that we had been doing here in Pickens County. So we interviewed 103 individuals that had been infected during the first 6 months of the pandemic, and found that 57% of them were reporting one new condition or one new long-term effect. So this number was much higher than anticipated, especially when you look at other research and other articles. We're seeing that, it's anywhere from 10 to 30%. We found a pretty significant number of individuals that were continuing to experience long-term effects. And this was 6 months after their initial diagnosis. What we found that was more concerning is that there does appear to be a social inequity piece tied to these findings. And so 79% of that 57% that reported one new condition were uninsured. 77% were identified as, put low income on here. These are individuals that are making, reporting an annual household income less than $50,000. 70% were Hispanics, and then 62% had underlying conditions. So, again, as we consider and as we think about, next steps and what it looks like going forward, I think this data begins to really, highlight, the inequities and the concerns over, it's not just hospitalizations and deaths, although, that is, of course, a priority, and that is something that we are continuing to focus on and monitor, but it's also these long-term effects that people are experiencing. And, as we learn more about them, we kind of discover and unravel more things about these long-term effects. So these were just some initial data points from the study that we had done that, again, just sort of, mimic the need for, continued surveillance and monitoring and also resources for individuals that are experiencing these long-term effects. Next slide. And then on that same vein, there was a study that came out just a few days ago and found that a third of individuals that had previously had COVID, which they deemed as survivors of COVID, had a neurological or psychiatric disorder. So they looked at medical records of over 230,000 individuals, and this was done at the University of Oxford. And again, about a third had a diagnosis of a neurological or psychiatric disorder. For about 13% of individuals, that was their first diagnosis of such a disorder. And then the other 20% had previously had, similar diagnoses in the past, but they had exacerbated or been re-diagnosed following COVID infection. So 24% had a mood, anxiety, or psychotic disorder. About 5% reported insomnia, 2% stroke, about 0.7% with dementia, and then 0.1% had encephalitis. So when you look at those percentages, they might seem a little bit smaller, but when you look at the total number of cases, it's quite staggering. If you look at, stroke, for example, almost 5,000 individuals in this study alone had reported a stroke in the 6 months following COVID infection. Then dementia was diagnosed in about 1,500 individuals. So, it's, again, we've talked a lot about hospitalizations and deaths, but the long-term effects of COVID are really coming into light, and there's a lot more research being done showing just the concern over them. And then also just wanted to mention that they compared the individuals that had COVID, and they compared that to people that had the flu and other respiratory illness, and they found that those who had COVID were much more likely to report neurologic or psychiatric disorders than those who had previously had the flu or other respiratory illness, showing that there is an impact with COVID, and it's not just any sort of respiratory illness, but that COVID is really exacerbating these symptoms and diagnoses in people. Next slide. And then just, again, last comment on these long-term effects. The former FDA commissioner has been quoted as saying there is an enormous wave of death and disability from chronic diseases that may come after the pandemic. And he's referring to these long-term effects that people are experiencing. Is very concerned about the disability that may follow. And a similar comment right below is he's very concerned that there will be a disproportionate effect of people with low incomes, low education levels, and individuals that live in rural areas of the country or across the world, which is sort of mimicking what we had already found in our initial, small study here in Pickens County, is that there does appear to be a social effect to these long-term effects. So just, again, very concerning, and just another thing that, is important for us to keep in mind as we move forward and thinking about, what our response looks like. Next slide. So then last two slides here is, just sort of a, I guess an urge and a reminder to the community to not let up, and we're not there yet. We look back at these previous surges in March, July, and December. We had these lulls where we didn't have many cases really reported, and then we saw another increase. So it's just hard to know, right, what the next month or two is going to look like. We have a lot of, very good things on the horizon. We have a lot of, things to be encouraged about. However, it's hard to know, and it's hard to say exactly what the next month or so is going to look like. So this wave, is different in that we do have vaccinations that are reducing hospitalization rates, especially among older age groups and individuals that have been vaccinated. However, we also have variants increasing transmission and hospitalizations, particularly among individuals who are younger or who have not been vaccinated. And then the other thing that's unique about this wave is that we do have restrictions across the state and the country that have been and are being loosened prematurely, according to a lot of the experts at the federal level, especially when we're trying to combat more transmissible variants. So again, we're seeing this decrease, and it's good. We want to see that decrease. Less people are being infected here in Pickens County, but it's a reminder for us to continue to do what we're doing to ensure that we're preventing as many infections as possible. And last slide. So then just kind of as a summary, vaccine rollout has been extremely advantageous for those who are eligible and those who have chosen to take the vaccine. So, really looking at the age group that is 65 years and older, but of course, among anyone else that has had access to the vaccines. But then we have to continue to protect our vulnerable populations who have not yet been vaccinated. So we have individuals that are immunocompromised who have been advised to not, take the vaccine as they're still assessing it, understanding the effects of it. Children, of course, are not eligible, and then certain individuals who are pregnant have been advised to not be vaccinated. So continuing to protect those groups remains extremely important. We know that the B117 has significantly increased transmissibility and severity of symptoms among those who are infected, especially in children. And then again, we have a significant proportion of Pickens County residents who we believe to continue to be suffering from conditions associated with COVID-19 infection up to 6 months after infection. So again, the reminder is, we're continuing to protect against hospitalizations, death, but also from this chronic disability and those who were previously infected with COVID. So I think I'll hand it off to Dr. Levin at this point.
Thanks, Josh. That was really complete. And I think everything I'm about to present is very consistent with the messaging that we're still in this. We want to be careful about loosening any restrictions too early. Your point about vaccinating everyone, there's variants are on the rise, and we've got a very high high number here in Pickens County. And then also just to watch our younger population at this point for what we're seeing in other places. So I'll go through my slides here. I wanted to give a Aspen Valley Hospital update, and this is actually kind of a new rendition of the matrix I wanted everyone to know about. It's on the website, and it's on the data, the hospital dashboard. I just put that up in the upper right there, that you press on that. The new, if you haven't seen the new data dashboard, it's really well done. There's 6 or 7 different mini dashboards that you can go into, and this is one of them. And it's really well done. And as we go through this pandemic, we're collecting more and more data and having to organize it. So I encourage you to take a look at it. So this is on the hospital dashboard, and I'll go through each one. So the healthcare workers were in green on everyone and average daily visits and inpatient hospitalization. However, and this is reassuring, of course, but I just want to go through each one and let you know a little bit of a heads up that we're still in the green, but there's some, there are a few things occurring that are consistent with our messaging that we're still in this. So next slide, please. So this is the graph that you've all seen of the Aspen Valley Hospital employees out of work with COVID-like symptoms. So that's the blue, and the yellow is across is where we're in the green or below. So when we get above 6, we would go out of green into yellow, but we're still in the green. However, if you look at the right side of the graph, since the beginning of February, we have had kind of a consistent uphill trend of healthcare workers out, which is concerning. You can see our big spike in December, and then we went down as it kind of reflected again what was happening in the community with incidents and numbers. And so that really reflected here. And then we were low for about a month, and now we're creeping upwards. And as of yesterday, we had 5 that were out. And so we're really getting on the cusp of potentially pushing into that yellow zone. This is concerning, and we'll continue to look at it. Next slide. Thanks. So I want to show this, the emergency department visits. We saw 5 yesterday in the ER. We are continuing, as you can see across, we've kind of had this baseline that's just at times kind of gone above that 6 mark, which goes again from green to yellow. We're still in the green, but we've gone above it even in the past couple weeks, or we've gone close to it. So we're still continuing to see these patients in the emergency department. And we're kind of continuing to see them at a little bit of a similar rate that we have over the past few months. And again, we'll continue to watch this. So we're just pushing that edge. Next slide, please. And I wanted to show this. This is the graph for patients currently hospitalized with COVID-19 in Colorado. I wanted to present this and say, first of all, let you know that there are currently two patients hospitalized in Aspen Valley Hospital. And now since the beginning of February, it's really been 0 or 1. And now we've got 2. And interestingly, there's one of them is young, is 19. And so this really gives an example that young people as well can get very sick and hospitalized from COVID-19. If we look at this graph, and I just thought it was interesting to show this, again, the huge spike is in December, and then we went down. And since the kind of mid-March, we've started having this upward trend, and this is concerning. So we plateaued, as we all heard about, and now we're trending upward. And then if you compare it to the spike in the summer, which was actually at that time considered to be a big spike, we're higher than that. So this is concerning. And where is this going to go? We'll see. You know, I think Josh's point, which is so appreciated, that we are linked to the outside world, especially in Aspen, which is a travel destination. We have a particularly more of a challenge here with travelers, and we're linked to the, our hospital here is linked to the greater hospital system in Colorado. Next slide. Actually, if you go back one slide, I just wanted to say a couple more things about that. I had a couple more points. Yeah. So interestingly, and I think one of the big questions is, since we've started vaccinating, who's being hospitalized? Is it still the largest percentage of the 80 and older group? Is it the 70s, 60s? So we've seen this go down. Now we're starting to see it go back up again. And so I looked into ages, and it's really interesting. So the over 80, which was the greatest percentage of people hospitalized and dying from COVID-19, in the November-December spike, this is pre-vaccination, the greater than 80 represented 21% of hospitalizations. Now on March 28th, that same percentage, that same group over 80 is down to 7.3%. So it went from 21% down to 7.3%. we all think and believe that this is due to vaccinations and the efficacy of vaccinations actually working. Now, if you look at this, the lowest age group, the lower age group of the 20 and 30-year-olds in November, December spike, they represented 11.5% of hospitalizations, still a significant amount. Now on March 28th, that has increased to 25%. So they're representing a quarter of hospitalizations now, the 20 to 30-year-olds. Again, very significant. I think this is due to vaccination, and this is another argument to vaccinate everybody, including the younger population, that they're still at risk for hospitalization and death. And I think we're seeing the effects of the vaccination with these age groups. All right, next slide. Now, I wanted to include this slide. Everything that Josh had mentioned in terms of the long-term effects, we're seeing here in the Valley. We have patients who are suffering from the long-term effects of COVID. And now this is very exciting that the primary care office, the Aspen Valley Hospital Primary Care, has created two things. One is a post-COVID clinic for patients that do not currently have a doctor to care for the medical aspects, and then a COVID-19 support group. Now, I think everything that Josh presented in terms of the neurologic and the psychiatric side to these post-COVID syndrome is really, really important. We're seeing a lot of mental issues associated with this, and I think a COVID-19 support group is critical. You can go to the website. I put the website on top. This will come up, you pop down, and then you register, and anybody can register to be a part of this support group, and we urge everybody to. And I think this local response, creating this resource locally, is really important. It is frightening that over 50%, 57% have at least one long-term symptom of those that Josh had done his survey on at 6 months, is certainly very concerning. And these people are really struggling. They're struggling with a lot of medical symptoms, and they're struggling with a lot of emotional and mental health symptoms. So these are two different clinics. I just want to let everybody know about it. It's really exciting. It's starting April 14th is the first one. So I wanted to let everybody know about this and what we're doing locally to respond to this serious issue of long-term effects of COVID. Next slide, please. Okay, and lastly, I wanted to show you this last slide here. Oh, hold on just a second. Oh, they're going through really quickly. If you can go back, great. Okay, so I'm participating in a little project locally addressing COVID vaccine myths and really looking at them one at a time. And there'll be some short videos for each myth. And I really just wanted to kind of go through them quickly and state what the myth is, so the incorrect statement. And I'm working on this with Dr. Gail Misner, who has done all of these myths in Spanish, and all of this will be on the website, and there'll just be short little videos addressing each one. And also Dr. Tasha Knight, who is the one of the two local OBGYN physicians that work with pregnant people and directly. And so she did the questions associated with fertility and pregnancy and the COVID-19 vaccine. So I'll just go through each one. And again, I'm doing this because I think vaccinating is one of the most critical tools in addressing this pandemic. We're doing such a great job here. We've got the mass vaccination clinic tomorrow. I'm going to be vaccinating there. It's very exciting and an amazing collaboration that has occurred. And we're doing such a great job locally. And now we want to just make sure that everybody that wants a vaccine can, and just address any vaccine myths and hesitancy. So the first one is the COVID-19 vaccines are not safe because they were developed too rapidly. This is not true. They are safe. They were developed with the same protocols as previous vaccines. It was just an incredible collaborative effort that's really accelerated the process, but it was the same exact process. I'm not going to speak too much on each of these. I just want to run through them fairly quickly. And again, these videos should be coming out. So the next one, COVID-19 vaccines are not safe because the messenger RNA technology is new. Actually, the messenger RNA technology has been a couple of decades in the making, and it was used on SARS, and it's been used in in cancer treatment, and it's been used in a couple of other very a couple of others. So messenger RNA technology is not brand new. It's a couple decades in the making. Next one, thanks. COVID-19 vaccines make me sick with COVID-19. Not true. The COVID-19 vaccines do not have the virus in it. They have this messenger RNA technology, and Johnson & Johnson has a DNA technology that does not contain any virus. Next slide, next one. There are severe side effects to COVID-19 vaccines. There are side effects. Some people get them, not everyone. They are short lasting, they're flu-like, and they disappear within hours to a day or two. No one's been hospitalized from them, and they're expected because your immune system is mounting a response that is a correct response to the vaccine. So when you get these side effects, you know that your body's actually doing what it's supposed to do and mounting an immune response. Next slide. I can test positive for COVID-19 after getting the vaccine. So the vaccine does not give you a positive COVID-19 test because there is no virus in the vaccine. You can test positive after if you get the virus after. Now, there are a few people in the Valley that have contracted COVID-19 in the community after getting the vaccine, and most of them have not waited that 2-week period. So again, it's important to wait that 2-week period until the second vaccine or the first Johnson & Johnson before the full effectiveness of the vaccine. The vaccine itself will not cause you to test positive for COVID-19. Next. COVID-19 vaccines change your DNA and can cause long-term effects. COVID-19 vaccines do not change your DNA. They do not incorporate into your DNA. The messenger RNA vaccines do not go into the nucleus where there's DNA. The Johnson & Johnson vaccine, which has DNA, does not interact with your own DNA. So that's false. Next one. COVID-19 vaccines contain preservatives, egg products, animal products, microchips, fetal cells, and are linked to 5G networks. None of these are true. One of the reasons why it's so hard with the scheduling at the vaccine clinics is that once you open a vial, it's only good for 6 hours. That's because there's no preservatives in there. There are no egg products or animal products, microchips, absolutely not. There are no fetal cells in any of these vaccines, including the Johnson & Johnson, and it has no link to the 5G networks, which we've all seen on social media. Next. If I already had COVID-19, I don't need the vaccine. Not true. If you've had COVID-19, you still need the vaccine. The vaccine actually creates higher levels of antibodies that are likely longer lasting than natural immunity from getting the illness. Next. If I'm young and not at risk for COVID-19 complications, I don't need the vaccine. This is not true. If you are young, you especially need the vaccine now so that you protect yourself. You can still have severe disease. You can have long-term complications, as Josh had outlined. The long-term complications are not linked to the severity of the initial illness. So even if you have mild illness at first, you are not out of the woods with it at all. You could have something long-term. So it's really important that everyone who's young gets this vaccine. You're protecting yourself, you're protecting your friends and family, and you're protecting all the vulnerable people in your community. And it is kind of a moral choice at this point to help with the community and to get as many people vaccinated as possible. Next one. I have seasonal allergies, so I should not get the COVID-19 vaccine. This is not true. If you have seasonal allergies, you absolutely should get the COVID-19 vaccine. You will not have any additional allergic reaction to it. We have very extremely low rates of anaphylaxis, which is really the only major complication. And you are, as everyone who has gone through the tent, you're observed for at least 15 to 30 minutes afterwards. And there's medical personnel on site. But if you have seasonal allergies, you absolutely should get the COVID-19 vaccine. Next one. COVID-19 vaccines can cause infertility and miscarriage. There are no data that support this at all. This is not true. No vaccines in the past have caused this, and COVID-19 vaccines are not shown to cause this in any way. There's a lot in social media about this. There's no indication of it. We have over half of our pregnant people in this valley who have been vaccinated and want to be vaccinated. And so this is false. Next one. The COVID-19 vaccines are not safe for pregnant women or for those trying to get pregnant. Again, not true. It is true that pregnant women were not included in the phase 3 trials of these vaccines. However, there is no indication that they are dangerous in any way. And again, over half the pregnant women in this valley have received them. There's been no issues with it. There's no data at all about preterm birth or any type of complications associated with it. And I think there's one more. Oh, they're not safe if you're breastfeeding. Actually, they are safer if you're breastfeeding, because we have now found that the antibodies can cross the placenta and provide protection to the newborn. So again, not true. And I think that's it. Yeah, thanks. Thanks for the opportunity to go through those. I think, you know, as we're in this phase, we're open to everybody now. It's really important that we have everybody and as many people vaccinated in the community so that we get as close as we can to herd immunity. And just wanted to run through those. So thank you very much. Appreciate it. And
Thank you very, very much, Cam and Josh. Any questions for Cam and Josh? Yeah, Greg?
Yeah, thank you. Make sure I can see y'all here. I just wanted to, if we could, if there's somebody who has some experience with the psychological study about the anxiety, the 24% who have it sounds like it, I want to make sure I get the phrasing right. It's really mental psychotic disorders related to COVID. And what I'm wondering, has that been unpacked from something like PTSD? Is it the length of time of a certain stress level, the ambient stress level we all feel, is that contributing to it? Or does COVID itself cause a psychotic disorder? And I think that's an important distinction, because I didn't hear that today, but it makes me really worried that people might misinterpret, or maybe they'll misinterpret it the way I perhaps have. Did you understand my question? Is this just due, like, would a forest fire that went on for 10 months cause the same level of psychotic disorder as this virus has, for instance, or a war? Thanks.
I think, Greg, you're kind of talking about a chicken and the egg. Like, did the illness cause this, or is the kind of post-trauma from the illness causing it? I think there's a lot unknown right now, and we have seen a lot of people, many people with long-term effects that are experiencing emotional and mental illness. And what happened? Did it happen from the event, or is it happening from this continued long-term battling with these symptoms that are causing like a depression and anxiety? I think a lot is unknown. So I think it's a good question. I think the answer is probably going to be a combination of those. But really, I think because there aren't any specific treatments at this point, there's, a lot of research being done, and there are some options now, but there's no real specific treatments for these daily long-term effects that people are having, that are affecting their life on a daily basis. And I think that just weighs on them heavily. And so that support group is actually, maybe one of the more important, more important things for people.
Great, thank you. I can imagine not having had COVID and still wanting to attend that support group.
To point out that the neuropsychiatric are not necessarily psychotic. I don't think, and Kim can back me up on this, that there have been psychotic or schizophrenic type of disorders following COVID-19.
Thanks, Tom. I think that's an important distinction. Are there actual diagnoses that are psychotic diagnoses from it? I don't know that there is a large number of that, and I think that is still panning out, but I really think the majority is this depression, anxiety, and emotional illness that is as a result of these long-term effects. There likely are some that are coming out. I don't know if they're directly linked to actually having the virus itself in terms of psychotic diagnoses.
I would just add that the study it looked at mood, anxiety and psychotic disorder. So even though the title was looking at psychiatric disorders, that one particular bullet point that I mentioned, the study did look at psychotic disorder. The proportion of those who were experiencing or had been diagnosed with a psychotic disorder was much lower than for those who had a mood or an anxiety disorder.
Okay, Tori?
Thanks, Marky. I just wanted to put out a question there. Maybe Josh can answer this, but I'm having some confusion about the data that we receive. I see the state dial that also has case counts and positivity rates. And then I see data that we get for daily counts. I don't really know what to look at to understand. I don't know what the information, what I should be learning from the information that I'm getting, because I seem to be getting different numbers according to state and according to local. And I appreciate getting the data, but I'm just at a point where I don't really know what I'm looking at, what it's telling me, and what other people are looking at, what the state is looking at. So could anybody address kind of the information that we've been receiving, and what should we be looking at?
I can start, and then I don't know if Jordana wants, or do you want to start, Jordana?
Sure, Josh, I can speak broadly, and then maybe if you want to get into the additional details. So the state dial, our placement on the state dial is indicated by the metrics at the state, and those that incidence rate the incidence rate, which we in turn calculate into a case count, as well as positivity rate, tends to lag a couple days from our local data. So the local data is really most notably in the report that kind of comes across and gets emailed out. We've been trying to align to get all of the information up on the website in a more cohesive manner, because we know that both reports can be confusing. But what we really, when we look at our local data, it's the most recent, the most up-to-date, allows us to make sure that the state data is being counted correctly. Sometimes tests get held up, there's other things that come along, so there may be differences in them. It allows for checks and balances, and for us to confirm with the state if they are going to move us on the dial, that we are working from the same understanding. So our local data usually leads. The state data is what places us on the dial, but while things might pop up and look slightly different, overall they are aligned in the message that they are sending to us.
Okay. I don't know if I'm the one one that has confusion around the information that we're given. Maybe I am. I don't see anybody else kind of looking for answers there. So maybe it's just me, and I'll get through it, because like you said, they are numbers that hopefully reconcile in the end, but I really haven't seen that much, Jordana. I have not seen them actually coming together at the end. So I still see disparities, and I'll continue to send you emails to straighten me out when I get confused. I appreciate it. I have a question.
If I can just add real quick, I think, part of the reason why there's confusion is the state is continuing to report incidence rate, whereas they have, informed us that we should be looking at case counts. So when you look at the dial, you're going to see an incidence rate, whereas on our report, you're seeing case counts, which is what is actually being used to move us from level to level. It's extremely confusing. So when you're trying to compare the two numbers, you're not going to find that information on the dial. So that's part of the reason why there's the confusion. And then secondly, positivity rate, we're using all of our tests. We're using PCRs and antigens, whereas the state is only using PCRs. So you're going to see a little bit of a difference between our numbers, just because we're trying to give you the best idea of where we currently sit as a county. So the dial is going to use, they're going to lag, as Jordana said, but the dial is really what we need to use to understand where we're moving, because that's the data that the state is using to move us from one level to another. Again, our data is just trying to give you sort of a prediction of where where we're headed, trying to use, most up-to-date information that we have available. As Jordana said, we're working on discontinuing the report. The report was made a long time ago, before we really had, all that information updated on the dashboard from the state. And so we're trying to get all of that pushed onto the dashboard so that we can discontinue the report. That way it's, it's more consistent in the data that we're presenting to you.
And I appreciate seeing our data because it does have that tracking ability. It shows your day-to-days, whereas the dial, I don't have a reference from the previous day necessarily. So I do appreciate it. Patty, did you want to ask something that on the line?
Yeah, I ask this question every time John Peacock comes before the board because it's still confusing. The state's reporting one set of numbers, we're reporting another. And then where does that apply to what color we're in? And that's would be my second question that can be answered hopefully somewhere during this meeting. I don't know when, but we've been in yellow now for a significant amount of time, fringing onto blue. When do then these numbers, align up that we can start talking about going from orange to yellow? And that's the hard part for me, Tori, is that does the state see us still in orange, or are we the number showing us in yellow, and who's on first and who's on second? So that I think contributes to the confusion, I think, for Tori and and I don't think we're alone in it. I think other members of the public who look at this wonder the same thing and aren't necessarily seeing the comparative data. So I think it's always been a concern and a question since we started looking at data, how many months and months ago. The state was looking at one set, we were looking at another. We've never been able to truly align those numbers. So I guess it's something we've just been having to live with. But when can we go to yellow?
When can I do my presentation?
Yeah.
Okay, I know it was coming up. I just wasn't sure. Okay, thanks.
I have a question relative to the numbers. As you know, we also have that new report coming out, and I think it's updated about 4 o'clock in the afternoon. Oh, shoot. Shut up, phone. It's updated around 4 o'clock in the afternoon. It seems to have more data elements that are better in alignment with the state. Should we not pay attention to the 4 o'clock and then another one at 6? Jordana?
So I think the data team has been working on this. I believe the last update I got was that the daily update that got sent out was going to be, they'll have all of the elements that are included in that morphed onto the dashboard by the end of this week in a way that that aligns it and lets everyone know what to look for. So I guess this is the fair warning that we can still, we've heard that there's a lot of interest in continuing to get the daily reminders that new data is available. So we'll continue that, but it will just include links to say, go to the data dashboard. It has been, it's updated for today.
Brent?
Yeah, just real quickly, I said this a long time ago, but, and it may be simplistic, but, I always feel this is way too much information. That's me. I'm a simple person, and I want to know up, down, left, right. Are things getting better? Are things getting worse? Do I need to tighten up? Can I relax? Now, the reality is we really don't get the luxury of relaxing pretty much no matter what happens, because even if we're knocking this thing out of the park, which we're not exactly doing that yet, we still need to keep distance and we still need to mask up and behave almost in the same way. And I personally feel that there should be a narrative in the beginning that just says, in some really simplistic way, this week, this month seems to be in line with last month. Keep up the good work from the general public standpoint. Because for me, I look at that and it's overwhelming, and I don't see a lot of direction. And as I say, the direction is pretty simple. We really don't have the luxury of relaxing. So this information is really just to make us feel a little bit better that we're handling this epidemic, this pandemic, now almost entirely because of, or not entirely, but primarily because of the vaccination. And so my comment would only be that if there's any ways to simplify this, because most people are going to look at this thing and throw it away. They're not even going to look at it because they don't want to go to school to read the document. They just want to know, how are we doing? Great, fantastic, tear it up or, delete it. So that's just my thinking. Kind of goes along with what Tori says. There's a lot of numbers out there, and that's tough enough for people that are really good with percentages and statistics, and impossible for those that are not.
And Brent, that's something we can look into incorporating into our weekly newsletters that go out, is just a narrative, or where are we at, what should you be doing, so people don't even have to look at numbers.
Yeah, exactly. Because in the end, they really need to behave just the way they're behaving, because that's right. We either have to tighten down or stay the same. We do not get to relax yet for who knows how
long. Marky, I just have a couple more questions for Dr. Levin,
Okay.
if she's still there.
Sure.
Thanks, Dr. Levin. So, and I just because I'm trying to understand as much as possible. When you talk about AVH staff that's out with COVID-like symptoms, do they test positive for the virus or not?
That's a great question. We track COVID-like symptoms because we know that some of the tests have false negatives, right? So percentage of the staff absolutely test positive for COVID. And then there's some that test negative but have the symptoms, but because of the way we're addressing this in the pandemic, they have the same isolation and quarantine periods. And so it's the staff that's out of the workforce that makes an impact on the hospital for any COVID-like symptoms. So the impact is the same on the hospital, but you are correct, by some of them test positive, some test negative. Again, we know that there is a false negative rate for all of these tests. And so we continue to be as careful as possible with the symptomatic workers.
Patty, go.
Yeah. I want to tag on to that. On top of that, why aren't 100% of the hospital workers vaccinated? They should be. Those are the frontline workers that have the exposure, the greatest exposure. And so why are we seeing an increased number in COVID-like symptoms if we aren't seeing an increase in full vaccination?
And another,
I see Dave came on that one.
It's another great point. I'll just mention it, and then Dave, please jump in. I want to remind everyone that the vaccines are not 100%. The Moderna and Pfizer are 95%, but they're still 5%. And so across the state and the nation, we're seeing some people who are vaccinated that still get it. And that's why, especially now in public, even if you're vaccinated, you need to follow the same social distancing and masking. So that's one important point in that, Patty, which I'm so glad you brought up. And the second is that AVH, and I know Dave Ressler can address this as well. We have one of the highest percentage of, we all know that the vaccine is not mandatory and it is a choice. And we have one of the highest percentage of our healthcare workers who have decided to get the vaccine and are vaccinated. And Dave, please add to that. I think it's up close to 75%.
Actually, I think we're at 80 or close to it. So I was going to try to get a quick text out to try to answer the question because I don't have the most current number, but we're very high. And to Dr. Levin's point, Patty, really good question. We are not making it mandatory. And it presently, I don't believe, I haven't talked with the hospital that is, but we do have one of the highest rates of any of the hospitals that I've communicated with. And there's different reasons why some people have chosen at this point not to, but the overwhelming number of our staff that are involved in patient care, physicians and clinical staff are. And as Dr. Levin commented earlier, we are still abiding by all of the commitments here at the hospital in our interactions with each other, and we're all still following the rules, and we can't let down that guard.
Okay, well then that's great information, but let me ask another just to tag on to that. Thanks, Tori, for bringing this up. So then how many of those who have COVID-like symptoms have been vaccinated? And either are people who didn't, the vaccine still allowed them to contract the disease, but how many of them are because their symptoms are so COVID-like in nature, you're just being overly, you're being not overly cautious, you're being appropriately cautious in having them isolate or quarantine at home. Do we have that information?
Yeah, as we are seeing again nationwide in the state that there are some individuals who are fully vaccinated that still contract, and we've had a couple that that's occurred with as well, which is very consistent with what we're seeing nationwide and through the state. So again, it is a tribute to saying that once you're vaccinated, you're not bulletproof. You have made an enormous step towards combating the disease and the pandemic, and it's one of the most important tools. And I think it's going to be our tool in combating it. But having that and understanding that it's not 100%, and no vaccine is, and previous vaccines were really down in the 60s, 60%, 70%. And so these messenger RNA vaccines are really extraordinary that they're up so high at 95%. And I just also wanted to say, in looking at the hospital as kind of a microcosm and looking at our own employees and the percentage, if we can get the community up to the same percent as the hospital, up to 80%, we have won. We've gotten to what we think is going to be around herd immunity in our community. So I think it's a really high goal. And I think all the hospital employees have done an amazing job in getting vaccinated.
Okay, but my question also said or asked, how many of those hospital employees that exhibited symptoms had the vaccine, did not contract COVID, but their symptoms were just the result of COVID vaccine, which mimics a lot of the same symptoms of flu-like.
Oh, I see what you're saying. I'm sorry.
Yeah.
So you're curious about the effects of the vaccine that may be interpreted as having COVID.
Exactly.
Right. Okay. So when the vaccine's administered, these effects are expected. My understanding is that none. That we're really looking at the effects of the vaccine as being very different from being out from COVID-like symptoms. So the effects of the vaccine are expected for people that are going to get it within hours to a couple of days, and then they disappear. And so after 1 to 2 days, it's a very expected course in terms of being vaccinated, that your side effects disappear and they're short-lived, and it's very consistent with exactly having the vaccine. So we would not be looking at these individuals as being out for COVID-like symptoms. Is that correct?
Well, yeah, that's helpful. But when I contracted COVID, my symptoms were very short-lived. And when I had the COVID vaccine, my symptoms were very short-lived. So, I'm kind of one of those that I guess I'm just very short-lived.
And also,
I'm just very short.
There's so many different ways that this happens, right?
Yeah,
and so can you get COVID at the exact timing of the vaccine? Certainly.
Yeah, you could. Yeah.
That can happen, but we're not testing everyone right after getting vaccinated who has side effects for COVID. So we can't do that, right? But you're right. Like, there's no impossibilities here. Everything's a possibility.
I'm just thinking about the overall safety of those who work at the hospital. And that's of great concern.
Yeah. Brent, I saw your hand up.
Just real quickly, I thought that what Kim said there was pretty interesting. And the fact is that, I think, and I don't know where this should be incorporated, but just the fact that your healthcare workers have protected themselves close to 80%, you should do your part too. We're very close to that goal. And I think that kind of goes back to what I said before. I think people, and I include myself in this, we want direction. Yes, no, tell me something to do. I don't want to interpret statistics. I want to be told, I want to be reassured ideally, but I also like to be told what to do. And I think things like that, your healthcare workers are at 80%. We need to pull to get to that same level or higher within our community. Otherwise we lose. And that's simple. Everybody gets it. Okay, maybe they'll go make their appointment that they have been postponing. But anyway, I thought I'd just chime in with that.
Linda? Go ahead.
This question is for Dave or Kim. I find that the people that are resistant, do you have anybody in the hospital that actually makes an appointment with the people that are anti-vaccine to sit down and question why they're not taking the vaccine? Because I find that especially in like at community health, the people that are anti-vaccine are succumbing to the myths that Dr. Levin discussed today. And I think that one-on-one addressing people and saying, listen, you know, you're not obliged to have the vaccine, but just out of curiosity, tell me why you are resistant. And usually they'll come up with a falsehood, and that could be corrected. And I think it would be, you might already have that person in the hospital doing that, but I just wondered if you did or not.
I think that's a great idea. And maybe there could be some sort of minor task force if we don't violate some stupid HIPAA rule or whatever, and call these people and try to encourage them with the facts. You know, that this is, and maybe just that one-on-one to know that somebody reached out from the health department of some sort or the hospital, whatever, you know, maybe that would increase the percentages a little bit. Because I'm sure some people, you know, maybe even lack conversation. You know, they're getting their information from God knows where, but they lack conversation. Nobody's refuting this to them, or at least explaining it to them, you know, especially if they don't have a spouse or whatever. So that, I think that's a great weakness and a great thought.
Great. And thank you, Linda and Brent. To both of your points, we have our employee health practitioners that do work individually with staff and have those conversations, answer all questions. We really approach it from an informational and educational perspective, and not a browbeating exercise. We do want to respect individuals and whatever their perspectives are, but we want to make sure that they're properly informed. And so that's really where our work has gone into. And I have to compliment our Dr. Levin and our medical staff, Dr. Bernard. They're very effective at being able to provide information from a physician's perspective based on data that will help to inform every member of our staff. And I think that's part of the reason why we've had such a high success rate.
And then my final question for Dr. Levin. So of those that have the COVID-like symptoms or indeed test positive for the virus at AVH, is the assumption or is the contact tracing suggesting that they are contracting the virus at the hospital, at their place of work?
It's a great question. I know Dave can answer this as well. The evidence is that it's not, that it's outside the hospital. And I think if you look at that healthcare worker graph again, it really reflects and it mimics what has occurred in the community. And so I think, again, our healthcare workers out has reflected community spread and what's going on in the community, our incidence rate throughout the entire pandemic. And I think that's true now. So my understanding, and I don't know the details about each specific one, but my understanding is that it's typically outside, that there have been no known outbreaks in the hospital, and that we continue to follow full protocols. Nothing's changed, even though we have 80% of our staff vaccinated. We haven't changed what we do with PPE and how we, we're still screened when we go into the hospital for temperature. I mean, everything is still the same, which I think is a big tribute to, saying that in public places that, your behaviors don't change after getting vaccinated. But I think that's a good question. Did I answer it okay?
Yeah, absolutely. And, and that's my last question. I'll just say one thing so everybody understands why I'm asking this. As we look ahead at how we are going to either maintain measures, increase measures, change, adapt, what we're doing in order to deal with transmission of the virus in our community. I'm really interested in how we are tackling that and what we are looking at doing going forward. What I see from what Josh presented earlier was that our case counts seem to be reflective of our visitorship. So where before, over the last year, we have not really necessarily made that direct linkage, I think that we are seeing that we are seeing our case counts mirroring our visitorship. And what that makes me wonder is about the measures that we have in place, what we are doing, the 5 commitments of containment and how effective they are. What are we going to do moving forward? And this information just helps me kind of try to understand better our efficacy and our effectiveness in the measures that we are putting upon our community, as well as our visitors, and what are we going to do for containment. So that's why I asked these questions, and I thank you for the answers that you've provided, Doctor. Thank you.
Thank you, Tori. I'm looking at our time. Jordana, do you want to proceed?
Thanks, Marky. Next slide, please. So exactly to what you're talking about, Tori, want to dive into the conversation today about what our protective measures need to look like here locally, given the deep dive into the data and the understanding of what impacts our incidence rates and what is going to ultimately get us out of this pandemic is being able to vaccinate enough of our population before variants have an ability to take hold. So currently, what are we doing? What are the requirements? So the state executive order requires all counties throughout Colorado to follow the Dial 3.0. Picking County Public Health, we also have a specific local public health order that requires additional measures. Those additional measures include our local mask mandate that requires anyone over 2 to wear a mask indoors in public places, as well as outdoors if you are within 6 feet of someone else and can't maintain that distance. We require the completion of business and event safety plans. The Traveler Responsibility Code is included in the local order. The local order also includes some additional clarification on informal gathering limits applying to lodging, and a requirement for any business that has deals with guests coming to Pitkin County to inform them of the requirements within the county before arriving. And then also it details some of the quarantine and isolation requirements. So that's currently what we're operating under. Next slide, please. Very much, Patty, to your point, we have been in the orange dial level, and 5-star has been operating in yellow. As of yesterday, we have 6 of 7 days of metrics in that yellow level. The trigger is when we hit 7 of 7 days in that less restrictive yellow level, which we predict to happen today. We would, I have plans to touch base with the state this afternoon after 4 to confirm that we have met those metrics, and then would be on track to move into yellow on Saturday morning, which would then permit 5-star certified businesses to operate in blue level. So I think it's really exciting, very encouraging, but also to everyone's point, we continue to move down the dial, which is helpful in the direction that we do indeed want to be going in. Next slide, please. So the other changes that are coming our way. April 15th is what we've been getting information about from the state, the last day that the executive order requiring compliance with the dial will be mandated at the state level. The dial will remain as guidance. The data and associated report cards will maintain. The state mask order will remain through May 5th. And the state public health order will be issued or amended, and it will include an indoor event capacity limit and the snapback provision. So I think just to give more clarity around what that snapback provision is that it will state that if counties meet certain hospitalization metrics related to COVID, that they will be required to comply with certain dial measures. So we don't have details or any of the details of what the state public health order will look like or these changes will be, but this is our understanding of what's happening at the state level. Even amidst, what Josh shared, that we are continuing to see an increase in hospitalizations, an increase in incidents. And the state is really eager to bring this control back to locals, stating that locals really know their communities and should be the ones to put into effect the requirements that are dictated by their own current situation. Next slide, please. Some of the reasoning behind this is that many counties in the state have achieved and sustained very low incidence rates. We, as has been discussed, we know that counties who are home to ski resorts or these rural resort communities who do see a lot more visitors have seen higher rates of transmission and do acknowledge that it's going to take higher vaccination rates and additional protective measures to be able to get down to those lower levels on the dial where incidence levels are lower, and to be able to relax restrictions to be able to graduate off the dial. As I think both Josh and Dr. Levin have shared, if we loosen restrictions too soon, we end up losing the race against the variants. So we need the opportunity for everyone who wants to get a vaccine to be able to receive one. This is, as was stated earlier, an equity concern of those that are still able to contract COVID who haven't had the opportunity yet to be vaccinated. And thinking about the protective measures that we still need to put into place as a community, knowing that until incidence rates are lower, there's still quite a risk out there. So again, just with the state handing control back over to the local level, it is up to local public health authorities to be able to put those protections that are needed at the local level into place. So next slide, please. So this is where I will discuss our staff recommendation about what those local level protective measures we recommend being is to continue to follow the dial 3.0 and our local public health order through May 27th. So just for the first thing to outline here is that this is an effort that we are working on in alignment with other rural resort communities in recognizing the importance of keeping those measures in place, recognizing that we still have a ways to go before vaccinating, before all of our populations are eligible to be vaccinated. That eligibility just opened up last Friday. According to the state, between mid and the end of May, everyone who wants a vaccine in Colorado should have access to one. And so knowing that is part of the reason for this timeline as well. So some of those counties who are part of those rural resort communities having this conversation about what do we need to keep in place through the end of May, include Eagle County, Summit County, Routt, Gunnison, and Clear Creek. So we're having those conversations. Communities on the Front Range are having conversations about how they can align, because what we continue to hear from our communities is if you're going to make regulations and requirements, we would really appreciate it if they are aligned as much as possible regionally. If they are going to, if changes are going to be made, to give advance warning and allow folks to be able to plan for what's to come. Let's see. So I think that's the recommendation. The second bullet point there states that another important piece of this is to reevaluate that adherence to the dial and those local public health orders through at our next Board of Health meeting, with the idea that at that point we would be able to come back and also present if we feel like we would be able to graduate off the dial, and then what those protective measures would need to look like into the summer. How do we measure when we are in a place to be able to move on? So, this is something that that regional resort group is really trying to talk about, trying to measure, instead of just picking a date. Thinking about what do we need to have in place before we feel like those additional less protective measures are needed to be able to continue to have our community be protected. And so, the first step is if we can move, if we can continue to move down on the dial and maintain level green or even up into level blue for a while. Those measures, once we get there, the restrictions are really loosen up. Capacities go in often cases to 100%, but are just required to maintain distancing, and really are that taste of what are the restrictions that can be loosened as we move down the dial in restriction levels. The other piece of this is, the percent of local population that we need to be vaccinated. We think that what the state has laid out that we would be able to achieve by May would be about 70% of our local population being vaccinated if we continue to get the allocations that have been predicted by the state. So those would be the measures that we would be continually looking at, making sure that we're keeping an eye on, and seeing how we're matching up against those as we're moving throughout time to get closer to the summer. So I'll pause there for questions and discussion.
Any questions for Jordana? A quick one for you, Jordana. We saw that, I think it was route was in blue already, or were they green? Well, the question is, if the counties that were, there you go, route's yellow. You said Gunnison, which is green. How are they willing to align? What's your read on their willingness to align to, if you will, kind of the yellow strategy, or what you're proposing right now?
So I think that there's commitment there to align to additional measures. We still need more time to have that conversation about what those additional measures are. So this is part of what everyone's kind of having to go back to their local community stakeholders boards, as well as then kind of coming together as a region. What those counties that I mentioned have is an ability to have a board of health, or the body that would actually be able to issue a local public health order that would be stricter than the state. As we've seen, a lot of the ability of counties to be able to put things to put additional public health orders into practice has to do with some of the political leanings of their county commissioners, who often act as their board of health. And so in places where there may be no additional political will to do that, there's not the ability to have any measures that are stricter than the state. I'll say, at this point, some of the there's major buy-in from not only the rural resort communities, but additional communities on the Front Range and some of the metro area to align on a mask order that extends past May 5th. There's real recognition that, masking is one of the most effective tools that we have to protect against the transmission of COVID. And so that is a measure that's currently going on at the local county level, is trying to align on what that measure might, what that unified order might look like, because we recognize people travel from one place to another. And in the absence of state orders, when we know that cases continue to rise, we need to think about what are the pieces that we need to keep in place locally.
Thank you. Any other questions? Yeah, Greg.
Yeah, Marky, Greg here. I'm not sure if you can see me. Thank you for that, Jordana. I'm hoping that we come to some sort of agreement with all the regional communities, and I know that's going to be a heavy lift, but I think it's so important. I did want to ask a couple things, summarize a little bit earlier, just to make sure that I think I heard what I heard about moving forward. Brent talked about the executive summary simplification, and I think you noted that, Jordana, with Kim's point about if we could all just emulate what AVH has done regarding their percentage. I think that was a great point. I just wanted to highlight that and make sure that was noted. Also, we had, I understand that Dr. Misner and Kim are working on these vax myths that they're going to publish as videos. And I'm hoping maybe we could produce that as an op-ed with a list as well, because it's so easy to read it on a page. And I just want to make sure that that's published and we all know how to find it, whether they're videos and or a list. And I'd like to ask if we could, as you're speaking about keeping our mask mandate, I forwarded a letter to some of the public health people today, and a constituent who just is convinced masks are ineffective according to the literature he's read. And I'd love to have that list of the information on mask myths dispelled as well, because we still have people who are convinced masks are ineffective. And so I think we just need to constantly be putting this message out there, and any tools we can have at our disposal to direct people to would be so useful. I think that's, I'll leave it there for now. Other than that, it'd be great to get our population to 70% in terms of vaccinations. And certainly I would like to try to figure out how we can set a goal to incentivize our workers who are coming into the community, our locals, and even visitors. Maybe we can tell them we're aiming for a 70% population vaccination. Please help us get there and get vaxxed before you come, whether you're driving in from Garfield County or you're flying in from New York. It'd be nice to be able to put that message out there. Thank you.
Okay, Tom?
I'd like to comment about keeping our population figures as high as possible. As we know, the 2020 census for last year really was not prepared by the time of election results. And I think that those results are still not forthcoming. When the 2020 population is forthcoming, if we can count that, it might be 10 or 20% greater than the current almost 18,000 population that we're using now for Pitkin County. And that would make the denominator larger and the percent rate lower. In addition, I think we need to continue to pursue working on the number of second homeowners, perhaps a survey could be taken of the number of second homeowners from the populations that we have of the second homeowner homes, as well as the construction workers. So the cases that are positive among those are counted among those denominators.
Thank you, Tom. Any comments? Yeah, Tori.
I just need to get some clarity here from the last few slides. We were looking at, Jordana, you were sharing a slide that was talking about, I thought what I was getting was that the state was moving away from the dial. They were absolving their dial. Is that what?
Yes. So the state is moving away from the last day that the executive order requiring all counties to follow the dial is April 15th. After that, the state is leaving it up to local public health control for counties to put into practice the mitigation measures, the protective measures, the requirements that the counties deem necessarily at the county level.
This is all very odd to me. So the state, the dial is a place where the data is collected that shows you basically the severity of transmission in your area. And then it follows with guidelines and suggestions for measures to increase safety and reduce transmission. And now the state is going to not be giving the advice of health and safety utilizing the dial, but staff recommendation or team recommendation is that we continue to follow guidelines in the dial. We recently were trying to align ourselves with what the state was saying. We were doing this for clarity and concise measures. And now I'm sorry, I'm struggling here. I'm struggling. What we have seen, what we have been doing, I'm not sure we could actually say has been effective. And now we're hearing from, I'm sorry, frustrating day perhaps, but I'm really having a difficult time following our train of thought from the data that we're getting to the regulations and restrictions that we put in place and where we're being effective. This is difficult.
And I just want to echo a little bit of what Tori said, and he had a key word in there, clarity. And I think that is an issue that we've been struggling with right from the beginning. And that kind of goes to my point about a narrative or some executive summary, because, TMI, too much information, especially when it's data driven, is terribly confusing. And I think that, and again, I'm probably missing the point here, but doesn't this mean that if the state is not enhancing this chart mechanism and whatever we call it, then they're going the other direction and abandoning it, which means it didn't work well, or it didn't do what they thought it would do. Now that really bothers me no end. When people are literally dying out there somewhere, and on local levels, restaurants are going out of business and it affects people's lives and all the rest, and to have mixed messages, to not have clarity, to not have effective communications is just a huge thing. And this is all, we're sort of learning this on the run. So, I can't blame anybody's efforts, although I just hope we've learned some big lessons for the next pandemic and we don't go through any kind of learning curve, at least the same learning curve. We've learned a lot, and hopefully we can give a simpler message more quickly. And like to Tori's point, we're doing all this, these regulations and modifying people's lives, and then to have the state kind of change the game on us a little bit, and turn it over to the counties. I mean, it seems to me that it's just, my view is it's quite the opposite. It should be the state, if not the federal government, that uniformly applies it to everybody, and that we have big expensive teams out there at the federal level, like think tanks almost, that produce a much clearer direction. Anyway.
I see John Peacock has his hand up, and John, you're closer to this in terms of working with the state than what any of us are.
Had the opportunity to be in some of these conversations with Jordana, and I just want to take a crack at reframing it. Don't disagree, Brent, with what you just said, that some consistency at a state and national level would be great. I think that's something to be hoped for more than expected at this point. And so the situation that we find ourselves in is when the state is looking at statewide data, there's actually a number of counties. They represent a small portion of the population, but a large number of counties that are actually in those blue levels, right? We understand that rural resort communities like Pickens County, like Eagle, like the communities that Jordana had listed earlier, have had the higher rates of mobility and interaction, and not surprisingly are on the higher end of incidence rates. The state is basically saying that on the 16th, they're keeping the dial, they're keeping the measures, they're keeping the guidance, but they are making it optional for counties to adhere to it. The counties like the rural resort communities, Eagle County, Summit County, Pickens County, Clear Creek Route, as staffs from those counties got together and said, we want to be sure we're coordinated on this exit strategy in our rural resort communities. So do we think from a public health perspective, we should abandon the dial and abandon the guidance, right? Right now. And the recommendation from staff from the various counties was, no, we're not there yet, because our incidence rates are higher than other communities in the state. And so the recommendation is for us to stick with the dial and the restrictions. I don't think I would argue that they haven't worked. Yes, we have higher incidence rates, but we also have higher testing rates, we have higher mobility rates, we have had higher risk factors, and we've done a good job protecting, I think, from death and serious disease and a lot of those factors. It's always hard to prove what doesn't happen versus what does. I want you all to keep that in mind. I think our picture, if we did not have any of these restrictions in place, if we had not followed these dial restrictions, we would be at a very different place in this pandemic right now. And so I do think there's been effectiveness there. But the real question is, do we come out on the state's timeline, or because our incidence rates are a little higher, do we come out on our own timeline? It is the recommendation of staff that we stick to the knitting a little bit longer and then evaluate moving away from the dial restrictions to protective measures that don't include the capacity limits from before. So I don't know if that made it more complicated or simplified it for you.
Well, for me, that made it more simplified. And this is certainly an argument for a different day. But it would seem to me, much like a general fighting a battle, you don't have, I'm not talking to us now, this is a general statement. You don't have the individual field commanders making decisions on their own. You have a central command that decides where you move and how you move it. And I hate bureaucracy, and I don't like bureaucracy. However, in pandemics, it seems to me what I've learned is that you want national control, perhaps even state control, so that you cannot have a county that says, look, we're a small county, we need to be in blue. Well, that sounds fair. But that's part of an overall battle, and somebody else who sees a more universal picture needs to help or be in charge with making those decisions, because you have people going through those counties. stopping in gas stations, eating whatever, and especially us in the Aspen Snowmass area, we have huge visitors. So all I'm saying is that I understand where we are. I just hope for the future we can centralize not only the data collection, but centralize the messaging and maybe even control. Again, I don't know how you control independent counties. That's sort of the way America works, and that's got some limitations there. But anyway, thank you. Thanks, Joe.
Yeah, and that's been our push-pull for the last year, no doubt. And this attempt at regionalism is doing the best job we can to create consistency where we can.
Thank you.
Do we happen to know where Garfield County is coming out on this whole issue, since they're not a resort community?
So Garfield did participate in the conversations. The Garfield Board of Commissioners, which acts as their Board of Health, had prior to those discussions already taken a position about reopening. And so, we have staff at the table. I'm not expecting that Garfield County would adopt the dial through the 27th.
Thank you, John. That just troubles me in terms of the workers who come up to Pickens County from the Garfield area, particularly construction. So, thank you. Tom?
I'd like to ask John how he anticipates things going in the next few months as we're immunizing more and more of the population, as well as not having the population of outside visitors here since the spring break is over. Do you think that we're going to accumulate a certain advantage during this period of time, or what will happen then as the summer approaches?
Yeah. Well, I may be the least qualified one to answer that, Dr. Kurt, but I think the prevailing wisdom is that we're going into a slow period. We know that we're going into off season, and I think the prevailing wisdom with the rural resort communities is that a combination of reduced activity while we're also getting more vaccines in arms is going to bring down our incidence rate, and it's also going to get us to a point where we're, relatively well protected if we can reach those percentages that Jordana was talked about. And so I think that was part of the logic, Dr. Kurt, of let's stay the course until the 27th. Let's get in to the off season. Let's really maximize suppression of the disease during our off season. Let's continue to get vaccines into arms so that as summer rolls around, if we've reached some of those critical thresholds, we can really start relaxing some of the public health orders in our next busy period. I hope that answers your question.
Thank you very much.
We may want to ask Josh and Jordana how I did, because they're probably more qualified to answer.
Okay, Jordana.
No, I think that's absolutely the thought process. And John, I appreciate the reframe. I think just really feeding, basing off of what we heard early in the presentation, that's all of the data for and evidence base for why we are recommending this. I think there was there was understanding that we're not out of this yet, and because of that, that's why we feel that keeping the dial, which will continue to exist, the guidance is there, our community understands it, until we have the opportunity to see reduced incidence rates, to have more of our population get vaccinated. That's going to give us the time to be planning for what do we need to have in place in the summertime that can be less restrictive. We're really looking forward to no capacity. How do we think about eliminating capacity restrictions and just sticking, if still needed, where with situations where we might still need masking or other kinds of, event safety plans, so that people are understanding what is still necessary while we are able to drop some of those other restrictions that we have been dealing with since the implementation of the dial.
Thank you, Jordana. Okay. Any other questions? Jordana, do you need a vote of support? Okay.
Yes.
Okay, can you put back up that staff recommendation, please? I think it makes a lot of sense that we continue to stick with the knitting. Remember, we're still in orange, and hopefully by Saturday morning, we go back into yellow. I don't ever want to have to move back into orange and then back into red. And I think the more we keep the pedal to the metal, I think I do like that extension. It's almost not quite 6 weeks. So Jordana, you want to refresh everyone's memory what we've got here?
So the staff recommendation is to keep our local public health order with the addition of following the dial 3.0 through May 27th.
Okay. Any questions? Any further discussion? Greg, is your
Marky,
hand
Greg?
up? Yes.
Yeah, thank you. There was discussion, I know we've heard about the snapback, and that sounds pretty ominous. It means the state can pull the rug out from under us, if we think of it that way. If things get worse, they can come back in and is that what the snapback means? That they could come back and put us under a stricter category or clamp down, or is the snapback something that's generated locally?
That is the state term that's being used. We haven't seen a written definition anywhere, but it's being talked about in terms of if counties are not following the dial and they have the hospitalizations reach a certain level due to COVID, that they can be then required to be placed on the dial.
Got it. Okay, thank you. If I could ask another one, just regarding capacity restrictions. I know there's been some talk about, for events, creating cohorts for capacity rather than households, or something where you could have vaccinated groups together 6 feet apart, or something, so you could actually get a higher number of people, say, in the music tent or at the event, and still have some way of ensuring that they're maintaining social distancing outside the cohort. Is that part of that conversation? Just want to know if that's been formally discussed.
The conversation of what might,
Regarding
what
capacity,
restrictions
yeah.
need to be in place for the summertime is the next thing that the staff is really going to be focusing on.
Got it. Okay. The other last thing, sorry, while I've got you here, we had a discussion, which I don't know if I initiated it or I thought it was going to be on the agenda, was just about what's going to happen, if anything, with vaccine passports are a subject of national discussion and state discussion and local. Just wondering, are we going to discuss that, or is that being considered? Can we come up with incentives?
I've got a slide for
Okay,
you coming up.
I
so
just
that's
jumped the
also
gun. Okay, I'll shut up now. Bye.
Patty and then Kim.
Yeah, Bart, Jordana, just really quick, and I apologize, I should know this. What's the federal level? What are they saying right now about masks? Is it still mandated? Specific, I'm thinking to airports and airplanes.
Thank you, Patty. Yes, masks are still required at the federal level. There's no end date to that mask order. It's just in place. It's required on in transportation settings. So that would be in airports, on buses, also on federal lands. And so that will affect places throughout Colorado as well as Pickens County. And their mask order is very similar to ours in that it is when you are outdoors, if you're within 6 feet of another person, you're required to mask up, and then also indoors.
Thank you. Thank you.
Yeah, Kim?
Thanks. Yeah, I just wanted to note, I think the recommendation is solid. I think what Jordana and John have explained, what I see going forward is a great opportunity for us in our county to really get as much of a handle as we can in the off season, vaccinate as many people, and create some consistency. So I know consistency can be different from what the state does. I think if we create consistency going through, it seems the frustration which we're all experiencing here is frustration coming from the state changing. And I'm certain that Jordana and her staff have experienced this frustration as well, that there's changes being made that we don't have control over. And I personally can see and anticipate every county each to his own. And I think that may be what's going to happen on the 15th. And I think we stay the course. We do the right thing. And I absolutely think our restrictions and what we've done have made a huge impact. And I don't think the reasoning is that these haven't made an impact and therefore the state is changing them. I think what's been explained is that the rest of the state, there's lots of counties in blue, and we've kind of gotten to this point in the pandemic where the state is just saying, hey, now let's just let each county do what they need to do for their own good and make their own decisions. And so I think we make our own decisions. I think it's a great opportunity for us to stay the course and be consistent. And there is not going to be any, what I think, and who knows, but every step is different in this pandemic. There will not be consistency likely among all the counties coming April 15th. So I think we do what's reasonable. We know they've worked. And that's my 2 cents. And I really appreciate John and Jordana recommending this and their explanations for it.
Thank you, Kim. John?
I just,
John, let me just jump in real quick. Kim, even without a pandemic, there is no consistency with the 64 counties. I just have to add that. Trust me.
Okay.
yeah, and I just think it's important, to add that the long-term goal here is to give vaccines time, enough time to get enough people vaccinated so that by the time we hit the summer, we're really able to look at loosening up those capacity restrictions, going to protective measures that maybe don't affect capacities as much. There is hope at the end of this. We just need to really, we just got a little bit longer in this battle. We're about there.
Thank you for those statements, John. I totally agree with you. Do I have a motion for support of the staff recommendation?
So moved or seconded.
Thank you. We have a motion and a second. Any further discussion?
Yes, please.
Yep.
I represent a board here, and having known that this was coming to us today would have been helpful so that I could have spoken to my fellow board members to represent what they would like to have either as information or input into this. So this is this puts me in a very difficult position. I think that there's more discussion that should be going on around this. As I said, we have problems here with compliance. We have problems here with enforcement. I'm glad that we feel like we are being effective, but I'm not sure we're being effective in the right areas. And so while this is definitely a cautious measure, and I appreciate that, I'm struggling again with what we are doing and how we're doing it, how we're going about what we're doing. What results are we trying to achieve? We've been so back and forth on our data, on our measures. Again, I go back to enforcement, compliance. We're putting in measures that I'm not even sure that we are getting compliance or the results on these measures. So I'm really struggling with the way that this conversation is going. I really wish that this would have been notified so that I could have had a conversation with my board members who I represent in this. Again, maybe it's my frustrating day coming through here, but I'm struggling with how this process is going. I don't know why the dates were chosen as the dates they are. I'm interested in the measures that are in the dial that we're wanting to follow, that the state is guiding us to not follow. I'm not hearing enough information on this recommendation, and it's frustrating me.
Greg?
Yeah, I just wanted to say, our board did meet and speak about this, and I think, was it Tuesday? When was the last Tuesday, Patty? So I'm a little surprised if your board didn't have a chance to talk about it. So that needs to be, I agree, Tori, that would be difficult. And so we have to fix that going forward.
So you at the county, you at the county level were apprised of this?
Our board's got to look at the staff, what the staff recommendation would be, and we discussed it at our last Tuesday work session. So we did see it then. I totally agree that city council should have a chance to talk about this so they can send you in prepared. But I can't help you with any of all the big question marks. They're still there and they've been there the whole time. I don't know how we'll get through that. We've talked about it today already, but so we probably we have a procedural issue regarding informing the boards, I guess.
Well, just so you're aware, I mean, we did not have this conversation until Monday night. Tuesday morning, we did send out an email update to staff, but that may not have given enough time, Tori, for that discussion. But these are the timelines, unfortunately, that we're working with.
Yeah, Anne?
Yeah, but isn't the 15th, isn't that when we'll make the final decision on our recommendation? That's what I was getting.
Well, next week, the
Or
state
13th,
public
I'm
health
sorry.
order, next week, the state public health order walks back the dial requirements. Right now, our public health order is written to follow that. And so if we do not, get some guidance and amend the public health order, then we, in essence, will only have the requirements that the state has in addition to our masking and event safety plan. So we basically will be walking away from all the capacity limits then.
And, I do agree with Tori. It would be good to see this, and for everybody on the board to see it a little before the meeting so that we get the questions out there. But to Brent's comment about consistency, I have been on a couple of those Zoom meetings with various counties and the state COVID people, staff, and the majority of people are demanding that it be local control and not state control. So
Right.
that may be this is the state's response to that very aggressive requests that control go back to the counties. We know better what to do with I actually think it'd be better to have consistency across the state, but from what I've seen, the majority of the counties seem to want to take control back themselves.
Yeah, it's almost as if Big Brother has been with us for well over a year, and Big Brother is saying, okay, you clearly you should understand the dial, you should understand the metrics by now. So let's let our children begin to manage themselves.
Yeah.
Is how I almost look at this. I was listening to Polis's press conference and I went, oh my, this is a lot of pressure coming from various counties. And I totally agree with you, Ann.
Yeah, one last point. I wish I understood a little bit better too, but I've tended to go the more conservative course throughout this whole last year and a half, whatever. And our Pitt County staff also seems to be more conservative. So, looking at it, I would support what you're proposing. But as Tori said, I think we both need to go get some feedback from the rest of our council.
If we want to take it back to council, then we would have to have another emergency meeting.
Well, I guess I'm not proposing. Yeah, sorry. It's a tough
Okay.
one. No, I think we need to decide on that.
Okay. Patty?
I think city council needs the opportunity, just like the OCC did. Sorry, the reason why we did it is because every Tuesday we have an update, a COVID update. We have it scheduled on our work session agenda time. So every Tuesday we get an update, and we've done that so that we can be prepared for Board of Health meetings or just be prepared in general. So, Marky, I don't know how you'd want to work it out too. I would not have a problem convening, a short Zoom meeting next week to actually take the vote, giving Tori time on, you have a meeting on Monday, correct, Dan and Tori?
Tuesday,
might have
Tuesday's a
to-
council meeting. Yeah.
Yeah, well, yeah, so maybe, I know we have BOCC meetings on Wednesday of next week, regular meeting. It's a long one, but we have time in the morning. I don't know. I think we can find a time where we can all call in it wouldn't take long to take a vote, 15 minutes. Or half an hour to do discussion. Further questions maybe could be answered prior to that meeting, but that's the only thing I can think of that might work, Mark.
Well, here's a philosophical question. I have no problems with doing an emergency meeting, but this board has 7 voting members. And the question becomes one, is it our policy that we receive jurisdictional support before we take an action as a majority of the board that I'm seeing wanting to move forward with a staff recommendation?
Fictional authority. I say this, Tori just wants the opportunity to know how to vote, to choose the voting member, how to best represent this council.
Yeah, that's one vote.
That is one vote, but every vote counts.
I don't know. You can call the vote if you want to. I don't think I'm going to cast a vote. I would like to confer with council, and mostly it's mostly about what input we could have towards this. As I was saying before, I just question our effectiveness. Is it helpful to wear a mask? Absolutely. Are capacity limits helping? Probably. But we're not winning the war here. So what are we supposed to be doing? What should be added to this? What could be being done to decrease our transmission rates? Because that's what we're talking about. Public health and safety, we're doing a good job, but we're not winning the war right now. So that's where I have questions about this. I think you should just go call the question if you'd like to, and I will confer with my board and let them know what's going on here. But I don't feel comfortable voting for this recommendation at this time.
Then that would require an emergency meeting. What's the pleasure of the team?
In general, I think we're winning the war now, but I respect Tori's input. If he sees any reason that he wants to call an emergency meeting to change this after he meets with this board, I think we might listen to him, but in the meantime, we will have approved it unless he votes otherwise with his board.
That's acceptable.
Okay, let's postpone the vote and do an emergency meeting on Wednesday.
No, I don't, Marky, I think that's not what Tom was suggesting here. He's saying to go ahead and have the vote as I take this back to my board for input and their feelings. Maybe there's something that could be added to it. If that's the case from my board, then I would be happy to request a special meeting.
I misunderstood Tom.
That's agreed. Yes,
Okay.
that's what I was saying.
Okay, that seems very reasonable. So do I have I think I had a motion to support the staff recommendation. I do know I had a second. So we're gonna go ahead and call the question. All in support, raise your right hand. Those who abstain or no? Tori, are you a
Abstain,
no?
thank you.
Okay. Okay. Okay, we look forward to hearing from you, Tori.
Thank you.
Next item on the agenda is, do we have more, Jordana, from you?
Yeah, I've got a couple more slides to go through. Just wanting to share that, the dial of, we've got the direction now to stay the course. I think that as we continue to look forward into the summer, we're going to be continuing to work with our regional partners to be able to try to align on what might be in place after that. I think the timelines are just coming up fast and furious. So as we learn where all of the other partners have landed in terms of what they're putting into place in the meantime through May 27th, we'll also try to catalog that and align and consider if there are things that we need to be thinking about, beforehand, before that May 27th date. If our numbers start looking differently, if we're able to vaccinate a whole lot of the population in some way before that date, these are all of the factors that continue to come before us. But what comes after this next step of the dial is what our staff will be working on. We will be reaching out to get feedback from the community, from community partners in that process of how we can help create those requirements that are simple, consistent, and aligned with the other rural resort communities. So just to touch on the commonalities of areas of potential protective measures to consider into the future, continuing to extend that mask order until it is no longer needed, continuing to think about what kind of distancing requirements and in what settings those would be required, the importance of continuing event safety plans and what that next iteration of safety plan would look like, transit expectations. So just to let this board know, April 15th will also end the 50% transit restriction that has been put on at the state level. At a local level, we have never restricted transit capacities, and we'll continue to work with our transit partners who span multiple counties for guidance on how they continue after April 15th. The 5-star program has some question marks. As long as we're following the dial, the 5-star program will exist and allow those that have been certified to operate at one level less restrictive. The question mark of does this program, is there a use for it after the dial goes away, is a question that we need to answer and bring back in the meantime. And then finally, the vaccination passport question. I guess not finally. The other reevaluation that will be happening is the traveler responsibility code. So we already had on that was something that we would be reconsidering for the summertime. And so that is something that we'll be working with our partners and coming back to the board with a recommendation of whether how that would be adapted or if it should be continued into the summer season. If there's not questions on that, the next slide is around the vaccine passport considerations. So, Greg, in response to those articles that you sent along, our staff has put together just some points for the board to be thinking about when this concept of vaccine passports comes up. So what we've noticed in looking at the programs that do exist is that all existing programs are exist at the state or country level, so New York or Israel, or are business driven. So this hasn't been done on a smaller level yet. I think, and for for probably very good reason. Mask wearing and distancing is still required, even where these vaccine passports are being required. So, we're having a lot of questions about, if we do this vaccine passport, can we not do the other required protective measures? And that isn't how it's currently being used. They can increase consumer confidence at events and large gatherings, knowing that the person standing next to you is immunized. However, some of the concerns is that it can also intensify existing inequities. So it privileges people who were fortunate enough to have gained earlier access to vaccinations. And so that really gets back to that, it's morally questionable to enact something until the entire population who's eligible has been able to have access to being vaccinated. It also privileges the vaccinated. Privileging the vaccinated will also penalize people with either medical reasons for not being able to get vaccinated, religious or philosophical objections to vaccination, and vaccine passports still just need to be considered in that light, while vaccination has not yet been widely available to everyone who would be eligible. Duplication of cards and the security of personal identifying information needs to be considered. So there's a whole lot of privacy protections and a system that would be considerations in these vaccine passports. We're still learning about the extent of protection against new variants and the potential for viral transmission by people who are fully vaccinated. So we're wanting to really know more before we can understand the full extent of the benefit of these vaccine passports. And finally, just really the messaging of a vaccine passport does have this harsh and extreme future connotation. So what we'd like to promote is really messaging tactics that can be more positive to trigger positive social behaviors and really instilling hope and having our community work towards being vaccinated at a very high level to get to that herd immunity.
Okay, any questions on the vaccine passport? Yeah, Greg.
Could briefly, Marky, right, those points are all really well taken. One of the articles I sent did talk about how there was a very large percentage of public that were polled that would be positive about the passport. So I think you need to include that as item number 8, that there's a large percentage of people in that poll taken, if you can hear me.
Yeah, Greg. And I think that's the consumer confidence piece that
okay,
people.
all right. Yeah, it contrasts pretty dramatically with item number 7. And we could go into details about all that. I don't think we need to, but I think we benefit if we had a conversation about how to incentivize people to get vaccinated. That's the point. So maybe the passport is one thing, but also I still think there are ways of creating incentives so that we can get our Valley workers and our locals and our visitors to really seriously contemplate getting vaccinated before they come in and become mobile in the community. So just wanted to say incentives still need to be there somewhere, maybe as part of a certification card or a vax card or something else. But thanks.
Thank you. I'm looking at the time. We almost need to move on to the 5-star program. Raleigh.
Thanks, Marky, and I will keep it quite brief. Next slide, please. All right, so as everyone probably knows, on March 24th, Pickens County moved to level orange, where many business sectors did have to move to a 25% capacity. 5-star certified businesses were the exception and have been able to operate in level yellow allowances. And as Jordana mentioned, if we stay on the same trajectory that we are on now, we would be able to move back to level yellow on the state dial on Saturday, meaning 5-star would then be able to operate in level blue allowances. The following day on the 25th of March, the 5-star administrative committee voted to accept and certify indoor event venues. And that's been an ongoing process, and we have quite a few venues certified. Next slide. So this is just a reminder of level yellow capacities. So majority are going to be operating at 50% capacity. And then on Saturday, if we do get that confirmation, a lot of businesses would be able to operate at 100% capacity with a 6-foot distance. So we would, of course, communicate that out to these 5-star businesses once we get that information. Next slide. Perfect. So as of today, we have 73 certified businesses. 56 of those are restaurants. 8 are from gym and fitness centers. 2 are from personal services, and then 7 are indoor event venues. And below on the slide, you can just see that if you go to our 5-star website and you kind of scroll down towards the end of the bottom of the page, you can see those drop-down options to look at all of those businesses that are certified. And so that way, you know, as a consumer, what business you're going to step into that is 5-star certified. Any questions?
Any questions for Raleigh? Thank you very much, Raleigh.
Thank you.
Next is the vaccination update. Carly?
We can't hear you, Carly. We'll have her try to dial back in. I can go through these slides if you want to go to the next slide. And Carly, when you rejoin, feel free to jump in. So in general, to date, there have been 11,600 doses administered at our Pickens County Pickens County site, with including over 5,800 people who have gotten that second dose, or at least 1 dose of Johnson & Johnson. And then we'll be up to 7,000 folks after tomorrow's Johnson & Johnson clinic who will be fully vaccinated. When we look at just residents of Pickens County, so who may have been vaccinated at our site or at any other location, we're up to 4,500 that are fully vaccinated. And again, the note that those are still estimates, as there's been there's always a bit of a reporting delay in that data. This week, we have second dose of Pfizer and Moderna scheduled on Friday, as well as 1,000 of the Johnson & Johnson single dose. Carly, I don't know if she's back on yet, but there has been a noted decline in interest in the 2-dose regime. And if you've got volume now, Carly, I'll let you indicate how you know that. Nope, still nothing. And so, you know, when there was last week's registration, it took a bit of time to get folks registered for, I don't recall if it was Pfizer or Moderna, but up to that clinic. But then we saw when we opened it up to the Johnson & Johnson this week, I think as was mentioned earlier, those doses filled in under 20 minutes. So knowing that there's definitely interest there. So this next week is really going to be the test in if there's still interest in both Johnson & Johnson as well as Pfizer and Moderna, and you know, just taking this opportunity to stress, while Pfizer and Moderna are 2 pokes. Aside from that, the best vaccine you can get is the vaccine that is offered to you at the time. They all do. They are all equally efficacious of reducing the risk of death and serious hospitalizations. And so, we would just, our vaccine, our comms team and Vax team is working on messaging to address that vaccine hesitancy, as well as some other efforts that if Carly has volume back, she can talk about how we're working forward to realize that maybe not everyone can make it to the vaccine clinic, and how we're addressing equity issues there. So next slide and see if Carly can jump in.
I think I can. Is it still no? Okay. Oh my God. Thank you guys. I'm so sorry. Thank you, Jordana, for jumping on there. Did a quick computer switch. I don't know what was going on. So yes, ultimately last week, I think we had a few variables in play between Easter weekend, the last busy season for our workforce. So that might've been the case. We are hoping to see a full Pfizer flat for first doses next week. And so having a pretty clear comparison between the Johnson & Johnson this week and 1,000 Pfizer next week, I think will give us a pretty good read on what's going on from public perception. So for planning through the near future, the big push right now is demobilizing that mass clinic. A big reason for this is kind of multifold. It's not necessarily that there isn't the desire for a mass clinic. A big push now is towards equity and is towards access. And so from one side, we're seeing sort of a lack of demand from our population, especially as I believe we go into off season, we're going to see that kind of trend down, as well as hoping to kind of bring the vaccine to where people are. And so that's a really big push. So we are looking at May 14th as being the last day of the mass clinic. Just so everyone is aware, we are actually moving sites at the end of April. So by the end of April, we are moving from where we currently are at the Benedict Music Tent parking lot over to the Buttermilk parking lot, which is exciting. The reason for that move was logistics with the Benedict Music Tent needing their parking lot back, as well as increasing access by being on the bus line, because that was a limitation that I believe our current site has, is it's not quite as accessible to that population. So by end of April, we will be at Buttermilk, same drive-through model, same walk-up capabilities on a bus line, which is nice. And by mid-May, we are hoping to demobilize that completely. That sounds very stressful and it sounds very like a big shift, but our cutoff is actually around 600 doses a week being administered at that mass clinic is realistically a non-sustainable option for that sort of model. Instead, what we're looking at for the future and sort of this long haul vaccination effort is going to be much more locally focused and population focused with many more but smaller clinics. So equity issues are a big one. We've heard this, I mean, every community has heard this from the beginning, but really trying to make sure that we make the vaccination process as equitable as possible by lowering these barriers, bringing the vaccine into comfortable situations for these populations. Access limitations, again, being on a bus line, being a drive-through clinic, certainly kind of limits and creates barriers to certain portions of our population. Working towards reduced hesitancy, so creating kind of a more familiar or a safer or a more recognizable clinic model for individuals who may be waiting to go talk to their doctors before they get a vaccine. So that's certainly part of it, is we are starting to talk about vaccine hesitancy and how can we overcome some of those barriers. And a really big push from this is increased vaccine uptake, kind of get to that 70% population threshold. And ultimately bringing the vaccine to them and making it difficult for people to come up with an excuse for why they don't get vaccinated. Because I think a lot of it is around comfort. It's a lot about capability of getting to the site. It's taking off work. And so how can we remove a lot of those barriers? So that's the near term. Can we hit the next slide? Thank you. So the biggest push that we can do to sort of ease the transition into this really long-term goal is increase our provider numbers. Right now, we've been so fortunate to have partnerships with Aspen Valley Hospital and public health and community health services to be able to put on this mass vaccination effort. Ultimately, that is not the end goal. That is not a forever solution. And so the best way that we can sort of increase access to the vaccine, really push for that 70% vaccination rate within the community is to increase our providers. And so primary care physicians, I know they had a big meeting last night to sort of broach the subject on how do we bring our PCPs into this conversation and how do we kind of lower the barriers that they're seeing. More pharmacies are coming online, which is very exciting, even our local ones, which is fantastic. And then ultimately kind of decentralizing that mobile clinic model where it's no longer this big central 2,000 a day, but a lot of many more, but smaller pop-ups that go to businesses that have experienced hesitancy, that go to population hubs that might not have been accessed before, to hit our transportation centers, as well as communities of color and Latinx communities. So that is the big push. I think that's the really sustainable model and really how we get people into the vaccine game, is giving it in a way that they are comfortable with. And sometimes the mass clinic isn't that for everyone. Big push for this, and as far as sort of advocacy and moving forward, is consistent vaccine allocations would be a game changer. Giving individuals, especially our working population, a few more days in order to schedule their appointments around their work schedules, around their kids, around school, around all the other things that go on in life, I think could really increase our uptake rate for our vaccines, especially in our current population. And a big push towards reducing, again, all of this is about reducing those barriers, increasing uptake, hesitancy versus vaccine watching, really sort of addressing all of these population concerns, and making sure that we really do make it as easy as possible. In a recent study, it was stated that within the United States, about 1/4 of individuals state that they are unlikely or unwilling to actually receive the vaccine. And basic math, that gets a little hard for us, right, to get to that 70%. And in Pickens County, I believe, based on what we saw at ABH and sort of in our prior eligibility phases, we've seen really high uptake. And so now how do we continue that trend into this younger population, the healthy, unaffected groups, and making sure that we really are hitting the message home that even if you are healthy now, even if you've already gotten COVID, even if you don't think you're at risk of that severe illness, it is not only good for you, but it is good for the community as a whole, in order to reduce those incidence rates, in order to keep the community functioning and the economy open. And so really working on those barriers. We are also working on including our young adult populations now that they are fully eligible under phase 2 into the clinic model. So our 16 to 18-year-olds, likely in our school systems, we are working very closely with them in order to make sure that we're doing that outreach. Pfizer is the only vaccine approved for that age group currently. And so going forward, we're really hoping to increase our Pfizer allocations in order to meet that need of that younger generation and make sure that, again, we're going towards protecting our schools, we're protecting our families, and really trying to create a little vaccine bubble around our kids until one of the vaccines gets approved for them. And ultimately, for the very long term, really make sure that we're continuing to maintain the capacity to vaccinate everyone in the community who wants one. And I think that is all I got.
Carly, are we getting enough vaccines? I think this week you wanted something like 3,200 and you got 1,000.
Yeah, this is a very complicated question. Are we getting what we're requesting through our orders? And no. A lot of the ordering politics is about kind of assuming that you're going to get much less than what you request. This week, we are actually incredibly fortunate that we were able to get that Johnson & Johnson, because I do think that's what the community wants. I think that we are about to test these 2 weeks between Johnson & Johnson and Pfizer. If we're able to fill 1,000 spots of each, then I would say that no, we are not. Then I want more vaccine. If we are struggling to fill one or more of the types of vaccine in that 1,000 dose pocket, I think that speaks to our strategy. And so if we are not necessarily able to meet the needs of the community through that mass vaccination model, that is why we're sort of starting to think about what comes next, is how do we make it more approachable for the population, in which case bigger allocations might not be what we need, but consistency. Being able to tell a community that we're going to go to them in 2 weeks and to work their schedule around, to find that babysitter, I think that will go a long way. So I feel very comfortable that I know we filled this week. I feel very comfortable that we will fill next week. But I ultimately think the big ask now is consistency and knowledge ahead of time of what we are getting. Because ultimately asking a working mother to take a day off and to have 2 days notice, that's a big ask.
That is.
Yeah, and so I want to find a way that we can get through around that and through those barriers.
Yeah, one other quick question, one that I got earlier this morning. I think it was Clark's is advertising that they're doing vaccines. Is there a
Yep.
cost for that?
No, so most providers, so the vaccine under the CARES Act and under the federal guidance, there is no cost to the individual
Okay.
getting vaccinated. What may happen is a provider may ask for your insurance information because they are able to bill insurance for the minimum. And that way they can kind of reimburse some of those costs to their staffing. But no cost to the individual getting vaccinated.
Okay, that's wonderful. Thank you very much, Patty.
Real quick, are we looking at any kind of a program to vaccinate the homebound? People who can't get to any of our clinics?
Yeah, no, excellent question, Patty. Thank you. So throughout this entire process, we've actually been working really closely with our Human Services Department with the county, and we have been implementing programs since January for our access and functional needs population. So we have not only been working with our homebound individuals who are pretty well connected into that system, and where one has been identified, we've been able to meet that need. But we've also worked with them to arrange transportation for individuals who might not be strictly homebound, but who need that little bit of extra assistance from a trusted caregiver to make sure that they're able to come to the vaccine site. So currently that need has been met. We've done about 1 to 2 every week, if we're being honest. Thus far, it's sort of tapered off now at this point. We certainly saw a little bit more when we opened up to our older populations, as well as our individuals with those 2 or plus comorbidities. But we continue to maintain that support system.
Somebody is truly homebound, can't get into any form of transportation.
Ooh,
Do we
I am
have
so
a
sorry.
service?
I am having a hard time hearing you.
Yeah,
I
Patty,
apologize.
you're breaking up.
If there's somebody who is truly homebound, do they have the opportunity to have somebody come to their home and give them a vaccination? Okay,
Yes.
so I'll call you just to get more details, because I'm just wondering, I've had people from outside our community asking us what we're gonna do, and I'll call you. I'll get. in touch
No,
with you.
absolutely. Please do. Because I mean, we certainly want to make sure that those individuals don't slip through the cracks, right? We know that we have a handle on the ones that we have a handle on. We definitely want to make sure that we continue to do that outreach. So thank you. Please do.
Thank you, Carly. Any other questions for Carly? Okay, good report. We are out of time. It's 20 to 4. Is there any questions or anything burning for a round robin, a quick round robin? I don't see any hand go up. So do I have a motion to adjourn?
So moved.
Thank you, Tom. Do I have a second? Brent, thank you. Final act. Thank you, Brent, for that, and all in support of adjourning. Raise your right hand. Thank you. Good meeting, good discussion.
And no, I've got a question, one last question. Marky, the next meeting, do I attend that or am I done?
I guess that's a Jordana question.
Jordana.
This is unless we have another meeting in April, Brent. We hope that you'll serve your term through the end of the month, but then the next one in May, we will be missing you.
Good. Well, all right. Well, thank you very much. Thank you.
Thank
Thanks for
you.
the
Thank
opportunity,
you all.
everybody. Thank you. Bye-bye.
Thank you, Brent.
Thank you.